welcome and a very good morning to all the participants. I'm Dr. Siti Sarah. I'll be presenting on ENT emergency for this ORL Awareness Week. So for ENT emergency, it can be divided into the organs, either ear, nose or throat or even neck. This is the outline of presentation today based on the topic. The first one is infection, and then ENT foreign bodies, the invasive fungal sinusitis and the complication of the rhinosinusitis, epistaxis, venous necrotizing otitis externa, and the complications of the otitis media, stridor, trauma, and also problems with tracheostomy. We proceed with the first topic, which is infection. For infection of the deep and neck spaces, it can be peritonsillar abscess, or other name is quinsy, Ludwig angina, retropharyngeal, and also parapharyngeal abscess. For quinsy, it happens when there is collection between the fibrous capsule of the tonsil, usually at the upper pole, and the superior constrictor muscle of the pharynx. The common organism including beta hemolytic streptococcus, strep viridans, Staph aureus, Haemophilus influenza, and also anaerobes. The treatment is mainly to emit for IND, antibiotic, IV antibiotic, hydration, and later on for elective tonsillectomy. So from the picture we can see there's enlargement of the peritonsillar space with deviated uvula. You can see here on the right side, small right tonsil there. So Ludwig angina is caused by the cellulitis of the submandibular space, in which it can lead to compromise of the airway because the infection is easily spread through the sublingual soft tissue. 80% of patients had dental infection in origin, whereas by the upper respiratory tract infection. So patient can present with diffuse neck swelling, erythema, and cellulitis of the skin. So on examination, you can see that the floor of mouth is raised and appear edematous. We can see on the right side picture. With the tongue push upwards and back, whereby it can cause potential airway obstruction. So this is a clinical diagnosis. So airway management is important in this kind of case, in which may require tracheostomy, and patient need to be admitted and observed with high dose IV antibiotic. Retropharyngeal abscess occur when there is presence of pus behind the pharynx, in which between the posterior pharyngeal wall and also prevertebral fascia. So this space extends from the skull base to the bifurcation of trachea and mainly resulted from suppuration of lymph node secondary to ENT infection. The clinical features is dysphagia. Patient can also present with stridor. And then on examination we can see the bulging of the posterior pharyngeal wall apart from the epistaxis and fever. So from here we can see there's widening, prevertebral widening. Okay, so we suspect there's some collection here, and then we proceed with CT scan. It can occur concomitantly with parapharyngeal abscess also. Parapharyngeal abscess, whereby the space lies on either side of the superior part of the pharynx. The presentation almost the same. This infection can spread into the peritonsil. It's spread from the peritonsillar area, or it can from the retropharyngeal or submandibular spaces. So from here, this scan, there's compromising of the airway, we can see, and patient can also present with occasionally torticollis. So all these abscess, the treatment basically drainage and also admission for further IV antibiotic. Other emergency condition is ENT foreign body. ENT foreign body is very common, mostly in children, and it presentation varies between adults and children, and the nature of the object and also the duration. For inorganic non-corrosive, usually non-urgent, required non-urgent anti-referral. However, if organic, living or corrosive, you need an urgent ENT referral. So for example, organic can be divided into living and non-living. Living such as beans, nuts, insect and bone, whereby in non-living, erasers, sponge, wood and papers. For inorganic material, example is plastic, metal, stone, any toys, button, battery. We proceed with the foreign body here. This example of the organic foreign body. So here you can see cockroach, kutu babi. So usually if these insects are still alive, of course it will cause a lot of pain. However, if it is died, usually I feel nothing, but it required to remove it. Okay, so I need to refer to ENT for removal. For inorganic, the example here are beads, cotton and also metal. This is also required in an ENT referral. However, since it's not living and not moving, that's why it's not like dying urgent now to refer if it is in the middle of night lah. If not, you can straight away refer to us for the removal of these inorganic things. How we manage to remove all these foreign body? It can either we can use irrigation. However, provided the tympanic membrane is intact, it is contraindicated if it is soft objects, organic matter or seeds, since it can lead to further dislodge the foreign body deeper. Apart from that, if under ENT, we can use suction or even hook with the crocodile forceps. For foreign body nose, we can suspect it when patient, especially children, presented with unilateral nasal discharge. So, or you can see visible foreign body from the nose. Or if it is a long-standing foreign body, it can also lead to the formation of rhinolith, like stone inside the nose. This is a very emergency referral in which you suspect for a battery in the nose. So it is because battery is a corrosive substance in which it can lead to perforation of the septum. So you need to refer us immediately so that we can remove it immediately, either under local or under general anesthesia. If we do it the foreign body removal under local anesthesia, usually we use either hook or spud in which we go beyond the objects so that we can extract it, scoop it out. Okay, if during the attempt we dislodge it further deeper, I think it's better to do it under general anesthesia, so it can lessen the trauma to the patient, especially to the children. For foreign body airway, the management for usually by less than 1 years old by giving back blows, whereby for if a bigger child, you can do gentle abdominal thrust or Heimlich maneuver. If unable to remove the foreign body, then we need to do it under general anesthesia. Or a partial obstruction, partial foreign body obstruction, it can patient can present with coughing, gagging, and also frequent throat clearing, whereby in the complete airway obstruction by the foreign body, it can lead to respiratory distress and patient will be inability to speak or cough. So from here we can see that for partial obstruction, it can still breathing the patient. However, if complete obstruction, it is a really airway emergency. For foreign body airway, So we need to do bronchoscopy under general anesthesia, so we can inspect and also remove the foreign body. For foreign body esophagus, is quite common in adult, okay, especially with dentures. Okay, from the X-ray, the basic imaging that we do, the lateral and neck X-ray. So make sure you have to visualize the C1 until C7, and then you look for any evidence of radiopaque foreign body, like in this picture. Is the presence of air trapping within the esophagus, any prevertebral widening, and also anterior displaced airway. If in children, the common object that usually occur in the children is coins. So how we remove it is in OT, general anesthesia, whereby we need to do esophagoscopy and also removal of the foreign body using the forceps. These are the pictures of our foreign body that commonly occur, which on the left is the fishbone and on the right is the dentures. That's why we need to patient, especially old people need to remove the dentures during sleeping. Now we proceed with the complications of sinusitis. For complication of sinusitis can be divided into acute and chronic. Whether patient can present acutely with orbital, intracranial or bony complication, or it can happen in chronic condition, which a patient presented with mucocele or pyocele. Why sinusitis can lead to a lot of complication? Because it happens at the denture area of the face, where it is from the corners of the mouth to the nasion. This area is a valveless vein area, whereby any infection even at the skin can spread into the brain. So for intracranial complication, it can lead to abscess, the brain abscess, meningitis, and also superior sagittal sinus thrombosis. Since our sinus is close to the eyes, especially the ethmoid sinus, any infection of the sinus, especially the ethmoid sinus, can also spread to the eye, in which can lead to orbital complication via either direct extension of the disease or from the retrograde thrombophlebitis. Bony complication of sinusitis, such as osteomyelitis of the frontal bone or Port-Coffey tumor, can happen as the complication of the sinusitis acutely, whereby the spread of the infection via the developed vein into the bone marrow, resulting in the localized osteitis and erosion of the anterior table of the frontal bone. So here we can see the circumscribed, okay, swelling over the frontal area. The chronic complication of the sinusitis, such as mucocele, can happen due to chronic obstruction of the sinus, with the commonest is the frontal sinus. It displaces the eye downward. So basically, this kind of patient require muscularization under general anesthesia. And then if the mucocele is infected, then we call it mucopyocele. Other nose emergency condition is invasive fungal sinusitis, whereby there is presence of fungal material within the mucosa, the bone, the blood vessel, and also the parastinasal sinus. This is usually happen in patients with immunocompromised, with diabetic, any AIDS or hematological malignancy, those on chemotherapy and steroid. So you can see here there's presence of blackish skin. Okay, we call it scar. Apart from that, patient can have also apoptosis, cranial nerve deficit, and also altered mental status. This is a very fast progressive disease. This urgent ENT condition in which required medical and surgical treatment, whereby medically you need to optimize the patient, especially the diabetic condition, and then start on broad spectrum IV antifungal, and then for the surgically you need to remove all this like a scar and also the visible fungal material so it can stop the spread of the infection. Epistaxis is also a common ENT emergency referral. There are many causes which can be divided into local and systemic. So in the history taking, you need to rule out all these local and systemic causes. Okay. And the epistaxis can be divided into anterior and posterior, whereby anterior is more common as compared to posterior. So the site is also different at the littlest area for anterior, and commonly occurred in children and young adult, whereby the posterior epistaxis usually occurred in elderly, usually due to hypertension or arteriosclerosis. And anterior epistaxis is milder bleeding as compared to posterior epistaxis. How we manage epistaxis? So once patient come, you need to ask the patient, teach the patient to do Trotter's methods by, if possible, to sit up and lean forward, and pinch the nose, and if you have eyes, you can put ice pack on the forehead. Okay, and then you can, if after like 5 to 10 minutes the bleeding still not stop, if you can see the bleeder, you can burn with chemical which is silver nitrate, or if you cannot see the bleeder, then you have to do packing, anterior nasal packing using bib, or in our hospital we have Merocel. Okay, if the bleeding is still not stopped, then you need to do anterior and posterior nasal packing, whereby in the posterior nasal packing you need the Foley catheters inserted into the nose. Okay, so as mentioned earlier, this is anterior nasal packing by either using bib on the left side. Okay, usually we use Tilly's forceps. Okay, is less sharp as compared to this kind of forceps, and on the right hand side you can we use Merocel. So we go in the next topic, which is the ear. For ENT emergency is the pinna seroma. You can see on the left side there is a swollen pinna. Okay, this condition is due to, it can happen spontaneously or due to trauma or post-surgery. What you need to do is you refer to us, and then we drain the fluid to see whether is it serous or blood, and then after that we need to compress it. Usually we use button, or if can, sometimes we use a dental roll and suture it front and back. Okay, and then we cover it with antibiotic. After a week we remove it and see whether it is reaccumulate or not. Other ear emergency is necrotizing otitis externa. What is NOE? It is an inflammatory condition caused by Pseudomonas infection, usually occurred in the elderly, diabetic and immunocompromised patient. This patient usually presented with excruciating pain with granulation tissue in the ear. Okay, facial palsy also is common. So we as an ENT, we diagnose using this criteria. We call it Cohen criteria, with all major criteria should be present and occasional of the minor criteria. Other ear complication that need urgent ENT referral is the otitis media with complication. This when we suspect that patient presented with a history of ear discharge or otalgia, then you have to further take the history so that you can suspect any complication of the otitis media. The complication is based on the spread of the infection, whether it can go intracranially, can cause meningitis, even brain abscess, any lateral sinus thrombosis or aortic hydrocephalus. Here we can see there's breach of the infection intracranially. So there's breach of the tegment. So the spread of infection goes into the brain. For intratemporal complications, the example could be acute mastocytitis, patient with facial palsy, or subperiosteal abscess. Apart from that, patient can also having a suppurative labyrinthitis. Okay. Other ENT emergency, the airway, which is Streidor. What is Streidor? Is an harsh noise produced by turbulent airflow through partially obstructed airway, either at the supraglottic, glottic, or subglottic, and also trachea, whereby you have to differentiate it with stertor, which is lower pitch, snoring like. And usually it happen because of the obstruction at the level of the nasal or oral pharynx. So Streidor basically is a symptoms, not a diagnosis. So we should investigate furthermore what are the causes. So there are many causes for Streidor. Either it can be congenital or acquired. So you have to determine the age, the onset and duration of the symptoms. So from here, you can see usually at the acute setting, is suspecting of infective instead of non-infective or congenital. So from here, we can see on the left is presence of epiglottic cyst, and on the right, there's mass at the foregut extending into the extending into the throat. Could be laryngeal carcinoma. Trauma is also a main bulk of the ENT emergency. Okay. The commonest is nasal bone fracture. So from here in the picture, there's presence of the nasal bone fracture. Okay, here is very subtle, you can see, but here you can see there's obvious nasal bone fracture with slight displacement. So in this picture, this patient, you can see that the nasal bridge is deviated, it's not straight. The main thing during the examination is you have to make sure that there is no septal hematoma. If you're suspecting for nasal septal hematoma, then you need to refer ENT urgently, because we need to drain it and decompress it by using nasal packing. So if nasal bone fracture per se, the treatment is mainly nasal bone reduction. It can be done under LA or GA, but usually we do it under LA. However, this reduction, we need to do it within 2 weeks from the trauma onset, because after that the bone will start to fuse, and we need septorhinoplasty if patient really wants to do corrective surgery, in which this is only can be done after 6 months of the trauma. Other ENT emergencies is a temporal bone fracture. This is whereby usually happen in motor vehicle accident. We have to see if there is any signs such as battle sign. You can see the bruises at the post-auricular area, in which indicate skull base fracture. So the fracture can be either longitudinal or it can be also transverse. Why this fracture you need to refer urgently to ENT is because we need to determine the onset if a patient develop facial nerve palsy later. If it is the facial nerve palsy appears acute during the onset of the accident, then we need to do facial nerve decompression immediately. And if later, it could be because of the edema. So there is still chance for conservative treatment. Neck trauma is also an urgent ENT referral, especially when you are suspecting a laryngeal injury or there's open wound. So in this picture, you can see there's presence of laryngeal trauma with exposed, maybe separation with you can see part of the ETT here, and this patient with abrasion of the necks, you need to rule out if there is any presence of laryngeal trauma. So it depends on the symptom of the patient, whether got any voice change, any difficulty in breathing. So if patient has this kind of symptoms, then you need to refer ENT urgently for scope and also for the management of the patient. Problems with tracheostomy are also ENT emergency. The problems are including suspecting blood tube or bleeding from the tube or surrounding area, any displacement of the tube, and the infection surrounding the tracheostoma. So this topic will be further elaborate tomorrow. Okay, that's all. Thank you for your kind attention.